So what I thought I'd speak to you today about monovision is just to talk to you a little bit about the concept of monovision, what different terminologies mean, and also talk a little about the results that monovision has had in refractive surgery primarily. So I'm going to go through a few terms just to make sure that we define it well. So I thought we'll start with what monovision is traditionally refers to. So monovision or full monovision actually means having one eye corrected for distance and the other eye corrected for near, where typically one eye is close to emmetropia and the second eye is at the maximum tolerable amount of anisometropia for that patient, which is typically somewhere around -2 to -2.5. So the second type of monovision is called mini monovision. Mini monovision is basically a reduction in the amount of difference between the two eyes, intraocular difference. So you have one eye that is corrected for distance and typically the second eye is corrected for intermediate and not for near. The advantage here is the fact that there is less change in the size of the objects and there is better binocularity in this kind of scenario. The third kind of monovision is called micro monovision. This is a combination of having distance correction in one eye and having a blended correction in the other eye, where you leave a significant amount of myopia, but then you also increase the spherical aberrations in the eye to increase what is called the depth of focus, so you have better combination of binocularity with both the eyes together. And then there is another terminology that is called crossed monovision. Crossed monovision is actually something that you don't aim to do. This is monovision where the dominant eye has been corrected for near and the non-dominant eye has been corrected for distance. This can happen as a mistake, can happen intentionally too. So what is dominance and how do you assess dominance? Because this is fundamental to understanding the concept of monovision. Ocular dominance basically means that one eye has a better representation in the visual cortex compared to the other eye. It has nothing to do with handedness. And if you're right-handed, it does not mean that your right eye is dominant. There are many ways in which you can measure dominance. The simplest way is just to use your hands out, ask the patient to look at a distant object, blink with either eye and see which eye you can still see the object with. That's the dominant eye. The same kind of concept you can use with a picture card. You can have a small hole cut out and have the same test. There's another way of checking dominance. You can ask the patient to point a pencil or a pen at a distant object in the room. And then with both eyes, once he closes both eyes, ask him which eye the object is aligned to the distant object that he pointed at. All of these are tests to measure ocular dominance. So how important or how reliable is ocular dominance? So this is actually a very interesting article that I came across where this talks about how you diagnose dominance and how it influences monovision. So what this article says that is they had two groups of patients, a younger group of patients and an older group of patients, and they found that in the younger group there was almost a 50-50% chance of either eye being dominant, whereas in the older group there seems to be a higher predilection for the right eye being dominant. What is also interesting in this article is when they actually tried to test both eyes for dominance in different settings with different test types, and by different examiners, they found that the dominance was actually shifting in patients. So these patients had right eye dominance, right eye dominant sometimes left eye dominant. So it wasn't a clear-cut one single eye that is dominant in a significant number of patients. So the other question that all of us have is if you have somebody who comes to you with a cataract, how do you assess dominance? Because one eye's vision might be less than the other eye's vision. Obviously, the eye that has clearer vision is going to be the dominant eye. Well, it's interesting again that when you have somebody who comes to you for cataract surgery and you look for dominance, 80% of patients actually have the eye in which the better vision is present as the dominant eye, whereas only 20% of them have the eye which has a worse visual acuity as a dominant eye. That means you have a patient who comes to you with bilateral cataract, he has 20/40 in the right eye, 20/25 in the left eye. 80% of the time, the left eye will be the dominant eye, 20% of the time, the right eye will be the dominant eye, in spite of the fact that he has better visual acuity. After cataract surgery, what is interesting is dominance seems to change in around 1/4 of the patients. That is, before surgery, if you plan that this is the dominant eye, I'm going to correct him for distance and correct him for distance, 25% of the time you might be wrong. So this is interesting again because this actually tells you that dominance probably is a moving target and is not something that is fixed. So a couple of interesting questions about monovision that I thought that I should answer. The first question is, what is the ideal age for monovision laser refractive surgery? So you can look at it from two angles. You can either look at the new presbyopes, that is the patients who have not really experienced presbyopia in the past or the recent presbyopes. These patients typically are not very good candidates for monovision because they have not experienced the pain of presbyopia and they are unwilling to compromise on any kind of visual acuity. Usually, patients who are between 45 to 55 tend to be the best candidates for monovision. Any older, the intraocular anisometropia is so large that they will not enjoy the benefits of monovision. Any younger, and these patients probably again are going to complain that the vision is not as good as it was before. So if you have a younger patient, the benefit is they might have some residual accommodation and they might actually be able to have better stereopsis, but then the disadvantage is the fact that they have not experienced monovision. So again, this is a very interesting article that I found in the contact lens field where they took early onset presbyopes and they looked at putting different kind of contact lenses on their eyes to find out which kind of lenses they prefer. And they found that patients who had monovision overall satisfaction was actually much lower than their satisfaction with their current prescription, showing that presbyopes who are younger probably are not great candidates for monovision. So the next question was about, is there a preponderance from male versus female? And apparently, interestingly, females seem to accept monovision much more as compared to males, and almost twice as many males tend to reject monovision as there are females. What about binocular vision? What happens to binocularity? Because obviously monovision means you're trying to see with one eye at a time. Monovision basically works by something called intraocular blur suppression. That is, if you have two images seen on both the eyes, both images are slightly different. The image that is slightly blurred is going to be suppressed automatically by your brain, and you're going to be seeing the clearer image. So you're going to lose binocular activity. So you also will lose some amount of stereopsis. Generally, the amount of stereopsis loss is around half. That is a 50% drop in stereopsis, but that again depends on the amount of monovision that you've given. And then depth of focus tends to reduce also in patients who have monovision. So what do you do when you have a patient who you are planning monovision for? One of the most important things to do before you do laser correction in patients like this is to use contact lens to simulate what they're going to see post-op. So it's important to try different powers of contact lenses, give them a home trial, let them take the contact lenses home and see which power they like. What is recommended is a minimum testing period of 3 weeks. You cannot test the patient for 1 day and say the patient, this is your correction, this is what you go for. Because 3 weeks is the adaptation time that people are going to take for monovision. So give them lenses, monthly disposable lenses, send them home. You might lose a significant number of patients to contact lenses in that way, but then that beats the pain of taking care of patients who are not happy with monovision later. So a couple of surgical considerations when you're doing monovision. There is something called the Regel's rule of 2/3. So what is suggested that if you have a patient who is approximately 60 years and has a near correction of +3, the amount of monovision or you're going to leave behind in the non-dominant eye should be 2/3 of the near addition. That is 2/3 of +3, that is +2 diopters. If you have somebody who has, say, 2 diopters, then obviously it's going to be 2/3 of 2 diopters, and that is the rule that you apparently should follow for patients who come for monovision. What is also important is a lot of times with laser refractive surgery, we tend to overcorrect a little, expecting patients to accommodate. When you are talking about monovision, you can't do that. You have to be spot on because these are patients who will not be able to accommodate. Avoid procedures that might require enhancements. So if you have a patient doing smile on for monovision, enhancing a smile is going to be difficult unless you do the surface ablation. So probably good to avoid smile. Larger flaps are good because enhancement rates are quite high. Almost 30% of patients who have monovision will require an enhancement because they realize they're not comfortable with what they're seeing right now. So if you have a hyperopic correction and you need to do a hyperopic correction after a myopic correction, always plan for a large flap early on rather than having to do a surface ablation later. So very quickly, I want to show you the outcomes of an interesting study that we did. I'm not going to go through the entire study, but this is basically an RCT or LASIK, PRK, and SMILE, where we try to look at the binocular vision function of patients who had these 3 procedures. The preoperative spherical equivalent of these patients was quite similar. Post-operatively, LASIK and PRK had a slight amount of hyperopia, whereas SMILE was pretty much spot on. The RMS values, the high contrast and the low contrast visual acuity between all these three groups were comparable. But what was interesting to see was the fact that when we measured stereopsis, and this was patients who were treated to be completely emmetropic after surgery. Stereopsis was much worse after surgery in LASIK and the PRK group, but in the SMILE group, we found that the stereopsis is better. So the reason I'm showing you this data is because I'll talk about the reason why this is so if we have time later on, is because what seems to happen is all these surgeries increase the amount of spherical aberrations in an eye. When you increase the spherical aberrations in an eye, you increase the depth of focus, which is the two focal points at which ends the rays start and end focus. And because of this, patients tend to have better depth of field even if they're presbyopic. So it seems to be an advantage to have SMILE later on. What about visual function and satisfaction in patients who have monovision? This again is in LASIK patients who are slightly older. This is before surgery, around 70% of them are satisfied. After monovision surgery, close to 90% of patients express satisfaction with their correction. So it seems to be a pretty good procedure. What is also interesting is binocular visual acuity is not as good as best corrected binocular visual acuity, but for most distances, most near vision up to 2025 and 2030, patients seem to be quite happy. Similarly, it's not perfect for distance vision, but then again, the majority of patients actually have acceptable distance vision too. So the question is whether monovision is for everyone. Probably not, because again, an interesting article that I found from the 1970s, it was found that people who are male and extroverted are probably the worst candidates for monovision. The best candidates for monovision are female and somebody who is an introvert. So just to summarize about monovision, what we spoke about till now, it's a very simple procedure that all of you probably are already doing, so it's not rocket science. Very cost effective, you don't need to invest any more money, you don't need to spend money on multifocal lenses. Binocularity is certainly reduced, but then in all procedures you probably have some reduction of visual acuity. Mini monovision is probably better than regular monovision, and if you don't like it or your patient doesn't like it, the best part is you can always reverse it, unlike a lot of other procedures that are done for presbyopic correction. Thank you very much.